Good afternoon. My name is Kurt Junkins. I'm the CEO for Navarro Regional Hospital.
And I'm Kent Rogers. I'm a physician and general internist, and I serve as your local health authority in the role of the medical director of the health department.
Gentlemen, there's been a lot of confusion lately on what a contact is, a COVID-19 contact. Can you explain to the general public on how they know or what they should do if they think they've been exposed and to what degree they've been exposed?
A contact is an exposure, and I'm saying what defines that. It's very seemingly arbitrary, but it's based on a lot of experience, and that is a contact occurs when an individual has spent 15 minutes within 6 feet of a confirmed COVID case. If that has happened, you are a contact. You are at risk for developing this disease. You're at higher risk than someone who has never made contact. You are not inevitably going to get the disease. If you look at the transmission rate, we're scared to death if one person gives it to 2 people. Now that has a terrible impact, but they may have been around 12 people. They just give it to 2, so that means the other 10 didn't get it. So your odds are you're not going to get it. But we don't know which 2 they are. So we have to round up everybody and isolate the contact. That's how you break this chain reaction that occurs that overwhelms a community. So we isolate the contact. I'll get to the details of that. A frequently asked question is, what if my child played with a contact? Well, that's what we begin to call a contact of a contact. And that, as you can imagine from the simple arithmetic of that, the odds are just not high enough that that person has received the virus to go through this whole process with them. That would be complete paralysis. So it's not to say there's no chance that that happened, but it's likely they're going to get it from somewhere else than being the contact of a contact. So contact of a contact, no new additional thing other than obviously be alert. A contact, someone who's been exposed, needs to isolate, self-isolate, so they cannot keep the chain reaction going. That means go home, stay at home, don't be around anybody else. That's the ideal. Now, what if this contact is the only neurosurgeon in town, or the superintendent of schools, or someone critical, that there's a huge impact if they're not at work and they can't do their work from home? The CDC has allowed some shortening of this with some caveats to 10 days, and then all symptom free, and then return to work, monitoring temperature twice a day, always wearing a mask, and distancing. That has been hedged towards 7 days. The truth in science is liquid. It's a moving project. So better data shows that the new onset of the symptoms in the last half of the 2 weeks is not as common. So there's some hedging. It kind of depends on how critical the job is, blah, blah, blah. So think of it, 10 days in isolation, maybe go back to work the last 4 if you're careful, as I pointed out. If you have the disease, you're the primary person, you had a swab, it's positive, what about you? That's 14 days from the time you were diagnosed, or from the time that clear symptoms developed, even though you may have been swabbed on day 3 of that. Your disease started as soon as you had symptoms. And likely that was when you became infected. And at the end of those 14 days, you are considered non-infected. Yes, your swab still may be positive, but you're swabbing dead virus that has not been cleared from the system. So that's a problem some patients are facing now in terms of getting back to work. If you are sick, and we put this into action before we had all the testing, if you're sick, you're going through this, and then you have 3 consecutive days of no fever with no anti-fever drugs, and your symptoms improved each of the 3 days, you're over. You're no longer infected. so you can return to the world at that point. Nowadays, with an abundance of caution, employers are frequently demanding negative tests. Certainly nursing homes are demanding of discharges from the hospital. And this is where science will help us out. Over time, we're going to discover, are we being too liberal? Are we wasting a lot of energy testing everyone? So we await, and those studies are ongoing right now. So that's the 3 tiers. I got it. I was around someone 15 minutes within 6 feet. That means I'm a contact, I'm at risk, and I'm around somebody who's a contact. Don't worry.
Kurt, can you tell us a little bit about COVID-19 testing and the different methods out there?
So the initial testing that came out associated with COVID-19 was driven off of something we call the PCR test, or polymerase chain reaction. This test basically looked for a replication of RNA and assessment to try to identify the COVID-19 strain. It came with some challenges under emergency use authorization. Any tests that are coming out have all been, through some rigorous processes, but are not necessarily truly FDA approved. But it is the best technology we had. PCR testing is what I've been calling it confirmatory testing as well. And in that, we basically, at this point, the hospital here does not perform that testing. We do get the swab and we send it off to a reference lab. These reference labs went through rigorous processes to do confirmations of that test before it was even in use, even with the emergency release. That's why we believe it's effective. There are challenges associated with these tests, sometimes as high as a false negative rate in the range of 30%, and thus we complement that testing with a symptomatic picture and now antigen testing. Our antigen test that has come out in the last month or so, that we have a pretty good supply of here, has allowed us to do a rapid test. That rapid test means in the short run of it, within 30 or 40 minutes, we're able to get a pretty good picture of, are you negative or are you positive? Recently, the company that's gone after this and created that antigen test has come out and said they're actually seeking, or will seek, but most likely here, actual FDA approval, not just emergency release use. In our own processes, this is a test that we do at our lab and on site. So in our ER or in our clinics or throughout the town, we're able to perform this. And so thus it arms us much quicker with at least a good picture of a direction here, particularly when compounded with a clinical picture of symptoms and otherwise. To that end, the antigen test appears to be very, very specific. What does that mean? Well, in laboratory terms, that means that if we get a positive test, it is very likely to be positive for COVID-19 specifically. Dr. Rogers, anything else to add there as to our testing capabilities?
No, those are the 3 tests. There is an antibody test that some people have heard about and get done. So the PCR is testing for the RNA of the virus, the antigen test for a protein on the surface, but it's rapid, which is very useful. And then this 3rd test is evidence that you've been exposed, same as this TB skin test or something. Sometime in your lifetime, you met this guy, you made a response, you still remember the response. So we're confirming that. Its use is really going to be later, like it is with influenza antibodies, to find out what happened last year. And it's very useful for studying the depth of penetration of a contagion. And we will be seeing publications on that, I'm sure, in a few more months, just learning how far off we were in estimating the number of people that have had and are having this. But it's not a right now test. It doesn't help immensely in terms of what do I do right now. So these other 2 tests are what we rely on. Plus, and he mentioned it, and that is the clinical picture. 3 people in my house are PCR positive. The antigen test is positive. We stop right there. I wouldn't believe a negative PCR at that point. So once you get a number of things that give you an odds ratio of 90+%, you can make clinical decisions safely at that point. So we are certainly better armed right now than we were 3 months ago when we were really in the dark. And we have available a lot more of the testing kits in the county. We're going to catch up, and we're going to understand better where we are, and that'll help us as we then begin to make some decisions on how further we can mitigate this epidemic.
Dr. Rogers, remind me, when you have an antibody test, is that counted as a positive sometimes or not?
We are presently not, we being Navarro County, are not counting that as a positive because with it, we don't even have clinical information. We have nothing to rate the likelihood it's accurate based on the story. We are counting, when you see our numbers, 200 and something, those are positive PCR tests. And we list probable an antigen test, the rapid test, that's positive, and that there are at least 2 clinical points that are positive in terms of symptoms or a contact, so that there's those together, your accuracy level rises to the point of treat them like they've got it. So that's all of these. The test only has 2 purposes, and one is treatment and one is prognosis. And if you're not asking that when you go get any test, forget this particular thing, then it's a test for curiosity. And if I have 10 warnings for young people, one of them is going to be, don't do tests for curiosity. This leads you down bad pathways and bad events. If you can't relate it to what am I going to do about it, or what does the future look like for you, then please avoid doing the test.
Gentlemen, can you explain or really debunk maybe some of the myths of masks, what they do, what they don't do, and why should I wear one?
Well, let me speak first as a hospital, as an employer. I think our facility and our teams have been under universal masking requirement basically for over the last month. And we've been asked this question a lot, and I think the challenge at play here is as much science as it is not just courtesy, but protection for the vulnerable and the sick. And for our situation, in an area where we have hundreds of people per day, the reality as an employer is, and as a healthcare provider, we have to protect everyone who comes in the door, as well as our critical staff members, as we see this pandemic unfolding. And so I'd ask, Dr. Rogers, in your opinion, from a mask perspective, why do I wear a mask if I'm within 6 feet of someone?
Okay, it's because the most common form of transmission is the droplet. These are droplets you might not even see, but they're easily seen with a laser beam of light, a plane of light right in front of your mouth. You can see hundreds per second as I'm talking now, but they're not getting to you because I'm catching them with this mask. And that's the droplet, down to about 5 microns, which is little bitty. Below 5 microns, those little water droplets float. So they're suspended in the air. They can have some viral organisms in them. So they stay maybe a couple hours, sometimes 3 hours in the air, suspended. This is not protecting me very much from that. We know that. But as I just said, the main way you can make me sick is with droplets. And those droplets hit the ground about 6 feet. If you're screaming, admittedly, it's 10 feet. That's 6 feet is the minimum. 10 is better, just to be honest. And but with the mask, my safety level is up. And so by you're wearing the mask, because you're not spewing that at me, and then you're better off because I'm not spewing at you. Now, I'm not being completely altruistic here. This is sparing me some of your, if I get up close, some droplets can hit. Actually, even wearing these glasses helps me some. not as good as goggles would be. But again, when you add things up in terms of risk and benefit, which we do every day, when we decide I can get across that street before the car comes, I'm going to drive to Dallas, take a chance, but there's a reward, I'm going to do it. We're constantly doing it. The brain does that all the time, and yet we seem to freeze up on this one. And frequently we say, well, if it doesn't work, this one time it didn't work, therefore it's bad. Of course, it's the childish mindset. That's not how adults think. Adults constantly are calculating risk benefit, and this guy is a lot of risk reduction right here, and it's not that hard.
Dr. Rogers, one of the things that I've heard asked is, even an N95 mask, a mask that's really used by healthcare workers that are in constant proximity to try to, really keep this out of their system, that the size of the virus can penetrate even a mask like that. Well, why are they still effective, or why not? And why does that matter in this case then for masking and source control?
Well, I think that every general will tell you in war that you can win more battles with a division than with a squad. And you can infect more humans if you bring millions of viral particles into the respiratory tree instead of 150. We handle 150 every 5 seconds here. We're breathing stuff like that, and we have systems that eradicate that. What we can't eradicate is when a division lands on our shore, and we only kill 90% of it, but the other 10% plants the flag, and we're infected. So viral inoculum, we call it, the dose of what you got is a big predictor of illness. Cut the inoculum down. Many people are exposed, but they don't get sick because they just got a little of it, and there are general systems, and I won't go into all of them, but they work, and they purge that out, and so no infection occurs.
So, Dr. Rogers, which masks are better for me to wear? If I have a choice of masks, what should I pick?
Really, one of the greatest masks is what the surgeons wear, because that's why they wear that, so they won't get stabbed from their nose down on my incision. A little bit difficult, tying up, getting all straight. A mask like this also functions well. It's pretty snug, and it's got a stay up here that keeps it on my nose. So there's most of the air going through here with the N95. 95, why is that number there? It filters out 95% of the small particles. And that's why it gets that rating. Now, that's if you have it fitting. And there are tests to ascertain whether or not it has to fit to get the 95 function. When it does, you are really dropping it. That's why they have to wear them, because they've got virus coming at them in the form of aerosol. They're in an intensive care unit, with ventilators. They're making that little spray that you can't see, and it suspends. They have got to be constantly protected from that, or they will be infected. But this N95, some people get infected, but I mean, every one of them would be infected without that mask in time.
So, gentlemen, can I ask, there's a lot of people out there that say the mask impedes their breathing or fogs their glasses. Kurt, you as a hospital administrator who have to ensure that all your staff is wearing masks a lot more than the general public in normal circumstances, and Dr. Rogers wearing a mask your whole professional career. Can you help us debunk that rumor, or is there any truth to that?
Well, I'll give you the truth. You can fog your glasses when you wear a mask, Chief. That's the truth, right?
Yes.
So the reality is that this has been an adjustment. I think even for many of our healthcare workers who maybe don't work directly with patients as well, folks that are, whether it's people that are our back office staff or other folks, the reality is it's an adjustment. But it's an adjustment that, well, my face feels hot, or it's a little bit different. I have to breathe a little differently. And certainly it makes an impact. If you're somebody who has a respiratory illness or otherwise, it could slow you down and it's a little harder. Does it cut me down to where I can't breathe or I'm having O2 problems? No. That's why we have nurses and doctors that wear masks all day long pre-COVID, prior to this, that do just fine. And they're actually very healthy and very capable. Dr. Rogers?
Thousands of people work in chip plants, work on our NASA rockets, sandblast, work in masks. I've done all those things. And I have a respiratory disease and I'm wearing a mask. I mean, you have to have pretty severe limitation. What the mask does is just adds a little bit more volume. You've got to ventilate that's not doing you any good. So it's like putting a couple of grams more on the scale. You do have to work a little bit harder. And if you're having to work a lot harder, the mask needs to come off. If you're such a respiratory cripple that it's impairing that, of course, now with the risk benefit went the other way, we take the mask off and we get away from you. And so that's how we solve it. But anyone who is trying to play the game, these are harmful to you, or there's a low oxygen level in here 1 second after you put the mask on, well, of course, there would be, but about 20 seconds later, everything is just fine. This is called an accommodation. It's like if you said, okay, Roger, breathe through a straw, and I'm going to make the straw a little bit longer here. That means I have to work a little. I've got to move that volume each breath to make the same exchange. I'm willing to do that to stay alive and to keep you alive. And I hope all the people in Corsicana, Navarro County, will begin to see this is an opportunity. We have these available. We can make them out of cloth. We can get these, I hope, will become more, they're sure comfortable, but they don't have a statement, I'll admit that. And then the N95s for our people that are breathing aerosol, like our EMTs, might be intubating somebody, they've got to have those. We don't want to mess with that supply. We want to use these because they're helping everyone else. Everybody doesn't have to be masked. People worry about that. Everybody's not going to do it, why should I? 80% masking crashes spread. Below 60, spread is wild. That's the zone to get into. 65 to 80% of all of us wearing a mask, we win. We can do this. But 65 to 80% of us have got to do it every day, all the time. And then we beat this guy.
So, gentlemen, when this started, Navarro County saw very minimal rises day to day, week to week, and on that 7-day average. Today, we announced we're at 241 cases in Navarro County. For medical professionals, one, does that worry you? And where do you think Navarro County is in relation to the rest of the country?
I'll start with that. I think as a healthcare entity, it worries me. The reality is that growth from day to day and week to week shows a continued spread in the community. But beyond that, it speaks to what we all need to do together to try to combat this effectively. So,
yes. So if one person gives one person this disease, whatever we start with, X per day stays X. And we can kind of adjust to that. Not if it's 300, but if it's down. But when you see the daily count go from 0.825 to 1, 1.6, over 3, then 7, and then 12 per day, now we're not on the plain that Chief Henley just described. We're in the foothills. And we're going to the mountains. If nothing is done at that point, it is inevitable, given you got 90% plus of the population totally naive to the virus, it will be 24 a day. And then 10 days later, 48 per day. 10 days after that, we're at the end of July. Nearly 100 per day. 100 per day. And then if that's unmitigated, it's 200, 400, 800. Now again, that's incomprehensible, and we've only got 50,000 people. We would probably get herd immunity by January, but we wouldn't get there. People will leave this place if that's what's happening. So we can't let it even get nearly that far. We have got to level this off. All you've got to do is get down to one person, gives it to one person. Once we're there, then we can start cranking and shrinking. We've got to get to one person gives it to one person only. And this is part of it, distancing is part of it, but not part-time, all the time. So, because you don't know, I could be carrying right now, and only Saturday I wake up, and then I'm thinking, oh, I was around these people, but thank God they were wearing masks, so we're okay. And because I probably didn't give it to them.
And I think that's what we're seeing play out, is that people are becoming more educated about maybe the symptoms too. Is so, even in the last couple of weeks, I think we've seen the same type of thing where people become aware of, hey, I've lost a sense of smell or taste. Well, that wasn't real common early on, and people have become knowledgeable about it. Now they're sensitive to it. And so I think that's where we're trying to go, is in order to bring that down, you've got to begin to be heightenedly aware of all those symptoms, right? Diarrhea, other symptoms on there, whether it's shortness of breath and some of the early ones like fever and sort of things that we saw early. This is now where the heightened sensibility, the awareness of who you're around, how we mask in the community to protect each other and really protect your neighbor, right? And how we protect your grandmother or your grandfather or someone else that may have comorbidities. That's, as a healthcare worker, what scares me, what I want to see protected, and how we really as a community come together to do that.
So, gentlemen, make no mistake, we are at war. We're fighting this war on many different fronts. There's a lot of people doing a lot of work to keep this community safe. What would you say to the general public who might not realize the workload that one positive gives to this community from a hospital perspective and also a public health perspective?
Well, as a hospital, when we have one positive, there is not just daily, but multiple times a day communication between our health department, our quality and infection control resources at the hospital, and our teams there are doing everything in their power to be aware of that patient, their health status, and how they're doing. That includes if they deteriorate and have to call for an EMS, for an ambulance, and then come to the hospital, trying to relay that system of messaging and improve that process so that when people come, we're prepared, that we protect other people that are there in the course of healthcare. And thus, as we go through that, we really have to rely on you to help everyone else around you stay safe.
Yes, so we try to be certain that the health department makes the emergency management team aware of all the positives, so if they're called to their address, they know full PPE and maybe a certain ambulance, so they are strategically focused on this. Certainly for the hospital to be aware when this contact moses in to get a chest x-ray, that we're aware they are on the list, and therefore we want to take the strategies, let them have the x-ray, but everybody's safe. That's very important. So for the patient or the citizen, communicating that you are in one of these conditions, I'm sick or I need to be evaluated, again, start with the phone, find the right way, because your primary care physician can guide you and get to the chief much more rapidly and safely than if you just start knocking on doors saying, what do I do? Call that person or call the health department, sorry Emily, and let us guide you so that you don't just wander around in the wilderness. We want to help you. But there are ways that we can, and then make everything safer. So it's interesting to me that the way that we're doing this is getting better. I'm old enough to have lived through seatbelts and other things that seem difficult, and yet I'm learning finally to get this mask on the same way. I don't crank the car like get that thing done. So I don't even think about it. So, and I'm not 100% perfect, correct, but highly compared to the first. So I'm getting better at this. You can get better at this, and just realize it's not going to be forever. It's months. This World War II lasted years. We can do this. We have done this, and we just got to think about each other here and allow safety to prevail so that we can work, make a living, and educate our children. That's what's at stake.
Gentlemen, I want to thank you for your time today, and I also want to thank you for the dedication that you've shown this county, this community. Your work is greatly appreciated. So thank you.